I forget. I go back and forth, and you know, I do OUs, and y'all guys do start a minute. And you guys start at a different time in OUs, so I can't remember where you guys are in the program. Okay, did you guys get the handouts for this lecture as well? The word handouts?
They might be.
Okay. I'll be sure to email you. I have a handout that goes a little bit more in depth, somewhat, to some of these fractures. So, you know, this is upper extremity. This is kind of your basic broad overview of upper extremity. You know, I am by no means an orthopedist, but I don't think for general, you know, PANCE testing and stuff like that, you don't have to know exactly all the different things that go with these certain surgeries and stuff like that, because they can get pretty intense and very specific about what you do based on how many millimeters and angles of whatever. You'll learn that on your orthopedic rotation, or if you decide to do orthopedics, you'll learn that as well. So there's obviously more specific. I mean, we could spend probably an entire week on the shoulder alone, a week on the elbow, and a week on the hand. But this is just your basic broad overview of orthopedics and kind of what to expect with certain processes. Excuse me. I mean, here, so this is your basic orthopedic treatment. I mean, this is going to get you 90% of what you need to do for almost all orthopedic injuries, from emergency medicine, primary care, urgent care, and most of the time, orthopedic standpoint. NSAIDs, Tylenol, ibuprofen, naproxen, ketoprofen, etc. You know, there's a lot of talk right now. It's 50-50 between who you talk to as an orthopedist about using NSAIDs, ibuprofen, naproxen in fracture care, because some of them believe that it inhibits fracture healing, and some of them don't. I haven't personally read any research papers that's come across my desk that definitively say NSAIDs impair fracture growth or slow fracture healing. I know that, you know, the mechanisms are there, I think, at some point, but the basic literature still supports the use of NSAIDs as your first-line treatment for a lot of orthopedic injuries. And actually, so I read an interesting study the other day that came across my desk. I think it came out either this year or early last year, and they did a trial for fracture care, non-long bone fracture care, so that's not femur, that's not humerus, that's not pelvis, that's hand, wrist, foot, ankle, things like that. And they compared the combination of 1,000 milligrams of Tylenol and 600 milligrams of ibuprofen given at the same time to oral opioids, oxycodone and Norco, and there was no significant difference in the time to onset of pain control or the level of pain control / pain relief in the Tylenol ibuprofen versus opioids. No difference. This is a huge trial. This isn't something that did it in the ER like, you know, they had 50 patients in their study. This was, I mean, thousands of patients that they did. No significant difference. And I can tell you from my own practice, so I've been doing this for probably about the past 2 months now. Unless you have a gigantic long bone fracture or something that looks really, really bad, or that I can tell you're just going to be kind of a pain in the ass, I go ahead and just give you Tylenol ibuprofen, and I've had a lot of good success with that. So keep that in the back of your mind, especially with all this stuff about opioid crises and stuff like that, and people getting addicted. And there is still some literature talking about people developing dependence addiction while getting their first dose of narcotics in the emergency department setting. So I think a lot of ER people are just like, oh, I'm just going to give them Dilaudid or morphine or Oxycontin or whatever here and not send them home with anything. It's not a big deal. Well, there's some more stuff coming out about the first dose you hit there, kind of giving some people a taste for it. Anyways, so NSAIDs, ice, 20 minutes on, 40 minutes off, 3 or 4 times a day. Activity restriction, rest, and mobilization. That's going to be specific for each injury and what you do. These are going to be your big ones too. You know, a lot of your overuse injuries and things like that, they're not going to get better unless you rest them. People have shoulder, you know, tendinopathies and things like that. Keep doing the same thing that got you there, it's not going to get better. kind of common sense. A lot of orthopedic stuff is common sense. Physical therapy and occupational therapy, highly underused for minor injuries, and really great for active pain control. So have you guys had x-rays and radiology and kind of stuff like that? Yeah, kind of. Yeah. So we're just going to kind of go over a little bit of brief fracture description. And you guys remember metaphysis, diaphysis, the epiphysis. This is all, review. And so here we have all sorts of different fracture morphologies: transverse, oblique, spiral, convoluted, segmental. The extent is a complete fracture, is an incomplete, crack, buckle, green stick. Those are all incomplete fractures that don't extend all the way out. Configuration here. And so these are all nomenclature that we're going to use to describe fractures. And you're calling an orthopedist at 3 o'clock in the morning because somebody has whatever fracture, and you say, oh, they broke their leg. That's not going to cut it, right? Because they're just probably going to hang up on you or yell at you. Relationship to fracture segments: displace, non-displace. So do the fracture segments line up, or are they apart? Now, whenever they're apart, are they angulated, are they translated, are they rotated, are they distracted, are they shortened or overrided? Those are all different terms you need to be familiar with. Shortening, obviously, is where it's going to be over the top of it and shortened. And overriding would kind of be another way to say that distracted means pulling apart so that they're going to be apart. And then you obviously can have different angles and rotations. There's all sorts of physics come into play here. And then, most importantly, I think, the relationship to the external environment. Is it closed or open? Huge, 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 huge. This is the biggest thing. If you need to start with something, I don't care if you get displaced, non-displaced, angulated, rotate. I don't care if you call it oblique fracture or spiral fracture. You need to know if it's closed or open, and that's whether or not it's puncturing through the skin, or that there's a skin break over it. That's another thing. So a lot of times I've seen fractures of humeruses that kind of come out, they break, they poke the skin through, and then pull back through some whatever kind of distraction and come back in. So you're not going to be seeing, it's not always going to be this gigantic bone sticking out of someone's skin that anybody can see. It may be just a little bit of a slice overriding it where that bone came up and poked through. So you need to really be sure of that, because if that bone gets exposed to external environment or bacteria in the skin or whatever, that sets you up for osteomyelitis and infection. Those things are really tough. So closed and open. You guys had peds right already?
No.
Oh, okay. Well, here's some peds stuff. Fracture description: Shoulder-Humerus is a classification scheme for pediatric fractures that go into the growth plates, PCO plates. Type 1 through 5, normal, and then here's kind of like a little mnemonic, I guess. You can always try to get that together, however if you want to remember it. I always say above, below, through, and crush. And then type 1 and type 5 are kind of the hardest ones to look at. I had a picture of one the other day that I wish I had brought to you. This kid, rodeo kid, 14-year-old, fell, had a bull step on him, on his wrist, and it didn't see any obvious breaks. There was no break in the cortex, the bony cortex. That's what we're looking for, fractures. But his growth plate here was a little bit more distracted, pulled apart from the other end, more than I thought that it should be for a 14-year-old. You're still going to have open growth plates in some places of a 14-year-old, but it was a little bit more open. And so that might have been considered a type 1 fracture. That fracture might have just gone right through that growth plate, opened it up a little bit more, and so you really couldn't see it. So these ones are kind of tough to go off because there's not a whole lot of break in that cortex that you can see through because there's already openings through there. Pediatric fracture, pediatric radiology is tough anyways, because when you look at especially somebody who's really young, 8, 9, 10, toddler, infant, Lord, their bones all look fractured because they all have holes and stuff going through all of them, and that's completely normal. Know this right here. I guarantee you this is going to be a test question either on this test or your boards. There's going to be a test question describing a Shoulder-Humerus fracture, and know what kind it is. Okay. Anything over those basic stuff? Nope. Okay. Cool. There's no clock in here, so I'll just kind of go off and watch, make sure we're behind this long one. All right, we're just going to jump into the shoulder. Glenohumeral dislocation, shoulder dislocation. So 95% of all shoulder dislocations are anterior nature, with 5% being posterior. Okay. Axillary nerve injury, these are most common. Nerve injured. Most commonly caused by fall on the abducted, externally rotated shoulder. Okay. Can anybody tell me what the axillary nerve does and what other nerve palsy findings you could find in a shoulder dislocation?
Axillary nerve here, trap.
Deltoid muscle?
Yeah, so you'll have loss of sensation on your deltoid here, and then you can also have some loss of wrist flexion too. So I always want to make sure, you know, the loss of sensation over your deltoid, you know, I don't know, what are you going to do with that? You know, there a lot of these things that come up in test books, and then in real life, you know, 60% of people that I see that fracture something say they have numbness around that area. You know, do I send those guys to an orthopedic surgeon, or I mean, there's not a nerve surgeon, right? So, you know, there's really not a lot you can do about that. You just kind of see if it comes back or not. Now, obviously, there's some more clinically, you know, this is a little bit different from having a little bit of numbness on your deltoid versus not being able to flex your wrist up. That's going to be a little bit different. So, those are two things that I always check. Sensation, and then, you know, just making sure that they can do one of these things right here. Is good to know. So your examination here, slightly abducted and externally rotated, loss of rounded appearance in the acromion right here. So I don't know if it's kind of tough to see. You see how this is really kind of got this nice fullness around here, and this kind of comes down straight. So if you were to palpate that right there, your fingers would just go straight in. It'd be like just pushing skin into nothing. And that, I mean, you can see that and just be like, yeah, that's dislocated. I mean, you can tell the more you see them, the more they classically look like that. Now, you can have some minor subluxations and things like that that don't quite look like that, but a true shoulder dislocation is going to have that loss of rounded appearance right there. You can just kind of feel on their shoulder, and you're kind of going down the top, around their acromion, and all of a sudden you're like, yeah, that's dislocated. Will resist movement due to pain, obviously. Their shoulders out, doesn't quite move really well. It hurts, you know, so don't give them too much of a hard time about it. They don't want to move their arm. So radiology 3 view, x-ray of the shoulder with axillary view or scapulary Y view. Scap Y is going to be your kind of radiology view that's specific for shoulder dislocation. So if you can't quite see it on your AP, or it's positioned wrong, or you have a high suspicion for dislocation and you're not quite seeing it, get a scap Y view. That may be another test question too, I would assume. I mean, that's you don't use that scap Y view for a lot of anything else other than shoulder dislocations. So normally the glenoid falls right in the center of the Y, is struck by the humeral head. And so we'll look at it right here. So obvious shoulder dislocation. This is not a scap Y view. This is kind of like an anterior posterior view. So I mean, glenoid cavity, acromion is obviously out, right? I mean, hopefully all you guys can see that, right? Again, out. Here's your scap Y view. So anterior, posterior, see the head of the humerus, see the Y, right? The head of the humerus is right in the middle there. It's going to be out of these two positions. It's going to be anterior dislocation. It's going to be posterior dislocation. On your AP views, a lot of times, sometimes it's tough to see whether it's anterior or posterior dislocation, but 95% of them are anterior anyways. Associated injuries, heel sac deformities, that's come from hitting the glenoid rim during dislocation, kind of dips that humeral head in. Bankard lesions, labral tears, with bony fragment avulsions, these are kind of more specific to orthopedics, and they'll kind of see those more in whenever you're doing surgery, things like that. Treatment, you obviously want to reduce it through manipulation of humeral head. Remember to always get post-reduction x-rays when you put it back in. Sling and immobilization with PTOT, operative if recurrent. So a lot of times you just put these in and just put them in a sling, tell them not to move it for a couple of days, have them follow up with an orthopedist, and then really get that in there. If it's, you're seeing somebody every week for a shoulder dislocation, or that, they go to, say hi to somebody and their shoulder falls out, then you might need it. You laugh, but it happens. Some of these people have just no ligaments in their arm, and they do something like a wave and their shoulder pops out. Timing on this treatment is pretty important. You need to get these shoulders back into place. The longer they're out, the more the muscles tend to kind of constrict and clamp down around that area, and makes it more difficult to manipulate. So you have somebody with a suspected shoulder dislocation, and you're in a busy emergency department that has 40 people in the waiting room, and you're seeing 250, 300 people a day. This isn't somebody that you just need to leave out in the waiting room for 6 hours. You typically need to get these people back and get it reduced quicker, or the harder it is. Or if you have associated vascular or nerve injury with those, it's not good to have that. So there's a billion different reduction techniques, and you can YouTube and Google all those sort of things. I use traction counter traction a lot. There's tons of different ways to get these things in. My favorite way to get these things in is the way that works. I do them all. I move that shoulder, I move it around, I get it into a place. Traction counter traction I think works best for me. Distracting the arm, kind of get it straight, and pulling it and rotating it out really works well too. You can just go through and look at all these things. This is typically what I do right here. So this is showing a straight arm. You can kind of abduct this arm in and pull straight down to get that in as well. Or put their arm in a 90-degree angle and use the elbow as a fulcrum and pulling out and doing some external internal rotation until you got to get that sucker in. It also helps looking at the x-ray, kind of, you look at the x-ray, see where their humeral head is, and see what you're looking, and then you kind of use your x-ray vision / picture what you're doing as you're manipulating, trying to figure out how to get that thing back in there, right? Everybody cool with that? AC joint injury, injury to the glenohumeral joint, coracoid and AC ligaments. There's type 1 through 6 sprains. It's in the notes that I sent out. They'll talk more specifically about the different types of strains. That's more of a specific upper extremity orthopedic type question. I don't think you're really going to get that on pants. Injury typically occurs from a fall or direct trauma to the acromion. This is a football injury a lot. You hear about the AC joint injuries from quarterbacks that fall and land on their shoulder, and they bust that right there. Tenderness palpation of the AC joint, cross-body abduction test, AC shear testing are all different types of special tests that you can do. So this cross-body abduction test reaches across your hand. And I'm not going to read this off. You can all read it off to yourself. Special tests, I think, are important to do. I don't do them in the emergency department because they don't really mean a whole lot to me, and a lot of people can't do the special tests at the time, 30 minutes after the injury, because it hurts to do them. But these are, make sure you review these special tests that I have in these lecture notes, because they're important for your orthopedic rotation and for the pants. I mean, you're going to see some of these kind of cross-body adduction tests, anterior drawer tests for the knee, Lockman sign, all those things. Those are typically test questions that people like to throw out because they're, those are gimme questions. There's no debating what the Lockman sign or anterior drawer test does. It does that, and that's it. AC shear test. Pain's AC joint when the hands are squeezed together. Look at what that guy's doing. I don't know. If somebody squeezed my arm like that, I feel like that would hurt now. let alone, that's why I don't know the sensitivity and specificity for that. You know, you hurt your shoulder and then somebody squeezes on it, it hurts. Like, okay. Go ahead. AC shear test, there you go. X-ray of shoulder, Zanka view, I've never ordered that before, allows the AC joint to be seen without overlapping images. Type 1 through 3, treated conservatively with immobilization and PT. Types 4 through 6, operative treatment with repair and damage. The types are in your notes. It just kind of differentiates the degree of separation on it. So 1 through 3, conservative. 4 through 6, operative. Right? Okay. Proximal humerus fractures. A lot of times in the elderly, majority treated non-operatively. Injury occurs from a fall or trauma. You know, young, healthy people typically, I mean, your humerus and your femur and your pelvis are pretty strong bones. You don't fracture those a whole lot unless you're in a car wreck or fall from some great height. But old people, good Lord, old people can fall from their knees and break every bone in their body. That just happens. Swelling, tenderness, palpation, pain with motion. Again, atrophied nerve, loss of deltoid sensation. Good. 2-view X-ray of the humerus, 3-view of the shoulder. Nearest classification based on the segment of the humerus, 1 part, 2 part, 3 part, 4 part. In your lecture handout notes, review the nearest classification. That's typically another kind of gimme question that somebody will ask you about different nearest classifications. You know, learn them now, don't practice orthopedics, get them later. So obviously you can see here we have a proximal humeral head fracture here. Is there any way to kill the lights just right here?
No.
Are you guys sure? Would that be better for you?
Yeah.
Okay. So this one here is a little tricky. I mean, you know, not super tricky because to me it obviously looks fractured. But you know, so you gotta look right here, kind of where this. So you can see how where this neck here. So obviously this is humeral neck fracture. I don't know why I'm standing so close to my pointer. Humeral neck fracture, and this is a shortened with overlapping segments, right? So they should be right here, shortened and overlapping because they're basically sitting right on top of each other. But you can see how this kind of surgical neck right here kind of comes into that head, and how it kind of starts at a line, and you get a kind of smooth thing, and then this is like, you know, it looks like somebody pushed it down. So this would be the fractures right through here. Depending on the nearest classification, depending on what they're going to do surgery for, you know, making this lecture, there's not a lot of things that I have in there about what you need to do surgery for. I think orthopedic PAs, once they start working and training with their surgeon, that's when you really learn. You know, I had an orthopedic surgeon tell me one time, you can teach a monkey to do surgery, but it takes a doctor, an orthopedist, to know when to do surgery. So that's kind of your big thing that you're going to learn is like, hey, when can these be treated conservatively with just some splinting and stuff, and when do they need to go to the operating room for what type of stuff? And good Lord, you need to spend 5 years in orthopedic surgery residency to get all that stuff figured out. So for these parts, for this type of stuff right here, we're just going to do kind of a general overview of what you do for management. Immobilization with a sling, plane control. You can try some coaptation splints. I don't think they work. It's like it's a big splint that goes from basically your mid forearm over and then comes over the top of your shoulder. It's just a big splint that comes there. I don't really think they work that much. Just use a sling a lot. And it's kind of weird. I mean, you'll see these old ladies or whatever that have just complete humeral, you know, mid-shaft fractures that are transected in 2 segments. And you're just like, all right, here's your sling, go home, you know. Yeah, but that's what you do with them, because there's really not a whole lot of, you know, you're just trying to treat that distraction right there, but it's not, you know, mobilizing it and keeping it straight is not a weight-bearing bone, and as long as you're not moving it, you're going to have a whole lot of fracture segment mobilization if it's immobilized. Complications, you get adhesive capsulitis. The higher up it goes, where you get kind of a frozen shoulder type syndrome where you can't move it. I think we talked a little bit about that more later. Again, mid-shaft fractures, radial nerve, most commonly injured, decreased wrist, finger, and thumb excisions, sensory loss of dorsal of the hand. This is going to be the one where you're flexing, right, radial nerve. Test question, I would think. Anyways, I should probably stop saying that. Your teacher is going to be like, quit giving away all my test questions. Initial treatment, coaptation splint, like I said, they don't really work that well, but you can use them if you want. Immobilization with sling, surgical treatment, ORIF, plate versus iron nailing. This is basically just putting a plate down the middle of it, nailing it together, or just putting a nail straight through it on both sides, kind of crisscrossing. Radial nerve palsy, non-union, those would be some bad complications of it. So anytime somebody has any injury to the wrist, always make them flex their wrist. You know, sensory loss at the arm sucks. Not as big a deal as not being able to move your wrist, right? That, you can see how that would be a pretty bad deal. Even if they have that, you know, not a lot you can do about it whenever you see it. You know. So pretty nasty. So how would you describe this fracture? So you're on the phone, it's 3 o'clock in the morning. Hey, Miss Susie Q broke her arm. She fell, tripping on, you know, whatever, her feet. And I don't mean to bash on old people. I love old people, but they get sick all the time, and it gets a little old sometimes. But anyways, how would you describe that fracture? Do you even take a gander?
Is it obliquely closed? Spiral?
Okay, so you got the orthopedic surgeon on the phone. Hey doc, I got a spiral fracture. Where?
Would it be mid-shaft humerus comminuted fracture?
Yeah. Okay, that sounds good to me, right? So comminuted because it's in it's in multiple pieces. It may be kind of this oblique spiral. You know, I don't really know. Those really don't mean a whole lot to me. So start from the very beginning. How would you describe it? From the very first word you say, hey, I got a closed fracture of the mid-shaft humerus that appears to be comminuted. Or you can say, I have a closed, comminuted mid-shaft fracture of the humerus. A lot of different ways that you can put that all into order. You can change up the order if you want. Closed, most important, needs to know whether they need to do surgery at the time, anatomical location, and then fracture morphology, right? And you can add those in however you want, but just as long as you say those three, right? So hey, I got a closed, comminuted, mid-shaft fracture of the left humerus. They have no radial nerve palsy. They have good cap refill. We can put them in a sling and swab, got their pain under control, and will you see them in their clinic in the next couple of days? And he's going to be like, okay, and they just hang up. Right? Supracondylar fracture, uncommon in adults. We'll discuss later in pediatric orthopedics. I hope you guys discuss it because I didn't make notes for it. I'm sure you guys are going to discuss pediatric orthopedics in your pediatric highlights. Clavicle fractures, typical in young children. Most common is the middle third. Injury caused by fall in the shoulder, pain, swelling. Tinting of the skin represents significant displacement or hematoma formation. So, oh, I think that guy's was broken, right? Yeah, that's not bad to me. So this would be tinting of the skin. That is a degree of subjective nature in describing. You know, clavicle fractures are non-emergent. They can be followed up outpatient unless they have a significant degree of tinting underneath the skin. Now, you can have a segment that's poking up so hard underneath the skin that it is stretching the skin so tight that you can have some avascular necrosis to that area, right? blood is not going to be able to go to that section of the skin because it's compressed by the bone so much that the skin starts to die or erode or whatever, right? So that would be something that you need to, have them see maybe next day or, later that night or whatever, if it's that bad. I can say out of all the clavicle injuries I've ever seen, I've never seen one where the tenting was that bad that it needed to be that way. But, something that you need to be on the lookout for. X-ray of the shoulder or clavicle, you can do a toned down view of the actual clavicle, or you can just tell your rad tech to say, hey, I want to get a picture of the shoulder. Do you have a question?
No.
Okay, you were waving at me. Sorry. You can tell your X-rad tech to get an X-ray of the shoulder and just give a widened view that includes their clavicle. That's typically what I do, so you don't have to order a clavicle and a shoulder because you want to make sure there's no associated fracture of the shoulder as well. Make sense? We already talked about that. Cool, way ahead. Distal third can be treated conservatively, or middle third, conservatively, distal third, need ortho eval, possible surgery, depending on how bad it's distracted. I mean, if your bones look like this, I don't know if I was, 17, would want to go the rest of my life with my bones looking like that. I'll be one straight now. So, how would we describe this fracture? This is no break in the skin.
Closed.
Closed. Yeah, mid shaft. I mean, I guess we can kind of measure that out. Maybe that's like right on the cusp of the distal 2/3. Yeah, you could just say segmental. I think that'd be right. It's just two pieces, what appears to be two pieces. Cool? All right. Rotator cuff stuff. Significant source of morbidity around manual labor in athletes. Everybody has rotator cuff tendinopathies. It's just, that's just what you get whenever you use your shoulder above your head over and over and over again. It wasn't quite designed to do that, I don't think. Over and over again. Swimming, tennis, baseball, softball, weightlifting, etc. SITS, S-I-T-S, acronym for your rotator cuff tendons, right? You guys know that? Okay. Know those. Those are easy questions to be pimped on an orthopedist, and then you ask them and you can tell them, and so you don't look like a total idiot. Shoulder pain with overhead motions, pain with abduction at greater than 90 degrees with internal rotation, so pain starts to get bad about right here, right? Nearest test, Hawking, empty can, lift off belly press test. Know those. Those are going to be test questions. I guarantee you that one of those are probably going to be on the pants. Nearest test, patient's hand rests on the scapula and on the forearm. Fully internally rotates, point arms down. Passive forward, flex the arm through full range of motion. Pain equals impingement / possible rotator cuff. Hawking's test. I'll let you guys review that. There's your kind of degrees. You said greater than 90, but it can start up here. But this is like kind of your spectrum for rotator cuff as far as when it starts to give them problems. But a lot of these tests aren't necessarily specific for. They're not specific for rotator cuff. They can be caused by a lot of different problems in your shoulder. That's why I don't really care for special tests that much. I am a dumb ERPA. I like it when tests say one thing, yes or no. I like to be able to do simple things like that. And this is not as simple. You just don't say yes or no. You say, oh, well, you maybe got something in there. Ultimately, you're just going to be ordering them more after that. Non-operative, basic ortho care like what we talked about in the first lectures. Steroid injections, no more than 3 to 4 a year. They can cause tendon necrosis, so you can do some intra-articular steroid injections, decrease the inflammation. So, with this tendonitis, this is not tendon rupture. This is tendonitis. This is inflammation of the tendon in the tendon sheath. So there's nothing structurally wrong with the tendon. It's got inflammation causing pain. So these typically don't need surgery. You just need to get the inflammation down. And you can try a variety of medications and steroids and physical therapy and whatever, try to get the inflammation down, but ultimately it's going to be you got to stop doing what hurts, right? Have you guys seen that meme with like the doctor and the old lady? He's like, my shoulder hurts whenever I do this, and it's like a doctor smiling. He's like, well, stop doing that, you know? I thought that was really funny because it's really true. So, activity restriction and PTOT. A lot of people forget about physical therapy. I mean, they just want to throw pain meds at it, want to do this, that, and the other. Physical therapy has a lot of benefits for these things, and I think that that's really underused a lot. People are like, oh, referral to orthopedist straight off the back, and you know, orthopedists get paid to cut, so they like to cut. You know, I think conservative management with PTOT is generally worth trying. Okay, rotator cuff tear. So, pretty much same as the previous, except the tendon is separated from the muscle, right? MRI of the shoulder to confirm diagnosis. So, same special tests, right? That's why they're not necessarily specific for tear versus tendonitis versus, you know, whatever problem you have there. That's why ultimately you're just going to need to get an MRI of that shoulder to show where the tear is, where the lesion is, and how severe it is. And then treatment for these, you know, if you get kind of an older person that doesn't really use their shoulder that much and they have CAD, hypertension, COPDs on oxygen and BiPAP and diabetes and they're at DKA every 3 days, probably not going to send those people to surgery. You can treat them conservatively, but for the most part, people that have limited, need range of motion of their shoulder back for activities of daily living, usually the treatment for surgery. Do it orthostopically, and they're pretty quick and easy. Labrum injury, so labrum is a cartilaginous tissue around the edge of the glenoid. Multiple different sites of the injury. Slap lesion is a common labral injury that you're going to see in softball players, in pitchers. That's the different sites where you can have that often occurs in shoulder dislocations or overuse injuries, pitchers, swimmers, things like that. Examination apprehension test, testing for anterior lesions, jerk test, posterior O'Brien signs. That's a slap tear, so that would be superior lateral, anterior, and posterior tear. So they kind of got upper, outer, front, and back. Non-operative, basic ortho, immobilization, gunslinger position. Right? Oh, that was fun. Whatever. Operative, if you fail conservative measures, right? So here's a deal on apprehension test. O'Brien's test, active compression test. So this is kind of another one you guys can look at, and I have more of these in my notes as well. Impingement syndrome, so a combination of shoulder symptoms that cause limited range of motion and pain. Positive Mears and Hawking signs would be for your examination. Pain with range of motion above the head and shoulder abduction over 90 degrees treatment. So these are just, this is going to be painful syndrome. Impingement syndrome is kind of like adhesive capsulitis. Adhesive capsulitis is where you can't move it. Impingement syndrome is where you get shooting type nerve pain, sharp stabbing pain at certain range of motions. Conservative treatment for 4 to 6 months, that would just be kind of a rest, immobilization, activity restriction, and NSAIDs. And then operative, if failed conservative, you can do it like a subacromial decompression, take away the pressure around in that area to see if that kind of helps. And so adhesive capsulitis, gradual development of global limitation of active and passive range of motion. This thing actually really sucks. It's like you can't move your shoulder. So a lot of times you'll get people in there and like, all right, I want you to try to move your shoulder. I'm like, I can't move my shoulder. And like, yes, you can move your shoulder, just try. These people can't, you can't force them to move their shoulder. It is like locked in there. 50 to 6-year-old women with diabetes, nagging pain at night, progressive global stiffness. You guys know what I mean by global, meaning everywhere, global like the globe, everywhere. Conservative surgical therapy is typically not helpful, but you can do manipulation. So, I mean, a lot of times you get, surgery, you get in there, you try to clean it out, but then that develops scar tissue, which then worsens your adhesive capsulitis and then just makes it worse. So there's not a lot you can do about it. Some you can do manipulation under anesthesia, where basically they just take you to the operating room, put you on propofol, knock you completely out, and then just rip your shoulder around and get it moving around. That's kind of a fun surgery. You guys will see whenever you get into orthopedic surgery, it's not like very nice and gentle. I'm going to place a small screw here and lift this up out of the way. It's very like, you know, it's fun. You guys enjoy it. I thought it was fun. Okay. Shoulder, I think, let me see what we got here. We're approaching, well, we still got 15 minutes. You guys are, okay. Elbow, do you guys have any questions over shoulder stuff that we did? Right? Okay, I mean, it's orthopedics. It's pretty simple stuff. Elbow-Olecranon fractures. Olecranon typically from fall directly onto a flexed or extended elbow. Down like that. Pain, turn this palpation over the Olecranon. And 4 range of motion, 2 to 3 view of the elbow. Need a true lateral to see the Olecranon because it's going to be your AP and oblique views are going to be overlapped with your radius and ulna. So that looks pretty bad, right? Olecranon. Initial treatment is splint with the long arm posterior, so long going up above the elbow. Always want to treat them, splint them in an anatomical position. So what's anatomical position? Yeah, at 90. So right here, palm up, to the back. Fracture with less than 1 to 2 millimeters of displacement can be splinted and treated conservatively. Fractures with greater than 2 millimeters of displacement need open reduction internal fixation, or IF. All right, radial head fractures. Mechanisms of foosh. What's a foosh?
Falling onto outstretched hand.
Yeah. With elbow extended, tenderness of palpation of the radial head with swelling, decreased range of motion. 3 view of the elbow. You guys learned about fat pad and cell signs in radiology? Good. Types 1 through 4 discussed in the lecture notes. Look at that little bitty little fracture. Man, I mean, that'd be, this is like really zoomed in and like a beautiful, clear, crisp image. That would be a tough one to see. But you can see there's a little bit of fat pad sign here, a little bit of an anterior, not too bad, but you guys already know about that stuff. Type 1, no displacement, can be treated conservatively. Type 2 through 4, need OR-IF. 2 through 4 are discussed in the lecture notes. Remind me to send those to you because I keep on referring to them. I need to make sure that you guys get them.
I actually found it. I uploaded it to B2L.
Oh, cool. Good. Okay, Alder head. Okay, that was radial head fractures. Now we're going to elbow dislocations. Most common is posterior lateral dislocation. Children more common, foosh. Obvious deformity with loss of range of motion. Your elbow is a hinge joint, hard to move your elbow when the hinge is unleashed, right? Take care in examining neurovascular status. Those things have a good time injuring the neurovascular bundles that come through there, and you make sure that they didn't catch anything. So always test cap refill under fingers. Always try to do good sensation testing, and you guys know the location and innervation of your different peripheral nerves in your extremities. So it's a different whenever this happens to somebody who says, I can't feel, I don't know, just my middle finger, that's it. It's kind of hard to get just your middle finger from back here, right? You're going to get these 3 and then a half and the other. So look for a distribution of nerve injuries in specific areas would be big key in on there as well. True lateral with 3 view of the elbow. Terrible triads. This would be an elbow dislocation with a radial head and choroid process fracture. I think why they have it, that's called a terrible triad in your lecture notes, but for some reason it's missing. Obviously it's bad because they move it that way. Closed reduction, splinting, long arm, referral to ortho. I mean, a lot of these things, these posterior lateral dislocations, you know, the elbow's a hinge joint, so you just gotta pull it down and let it pop back into place, right? So you can see here how this would be, you know, it's a posterior dislocation. Obviously kind of chipped a little bit of the bone right here, whether it's on that medial epicondyle on the other side, or, you know, a pace on the underside of the olecranon. You can see where that gets through. And so you can see how you just put your hands right here. One person's pulling down here, one person's pulling the arm back. Get it to sit right back in. Don't see those a whole lot. Those are not really great. Definitely need to call an orthopedist. Shoulder dislocations, I don't really, you know, I some follow-up as needed. Somebody dislocates their elbow, I'm probably still going to be calling orthopedists just to give them a heads up and see if there's anything different that they want to do, even when their exam is normal and I get them back into anatomical position. And don't forget, once you do that, to get post-reduction film to see if it's in the right spot. Radial head dislocation, so we're going to talk about a pediatric thing real quick, also called nursemaid's injury. God, I see these all the time. They happen all the time. Common in young children, caused by axial traction on a pronated forearm full extension. That's a fancy way of saying that some mom would have their kid and just yank them up real quick. Like they're lying on the ground, they didn't want to do whatever they were doing, and she just kind of grabs her arm and pulls them up, and then dislocates their radial head. Painful joint that the child does not want to move. They'll come in crying, mom doesn't know what happened, they won't move their arm. You know, a lot of different things. You know, these children are like 2, 3, 4 years old. They're not going to tell you, oh, it hurts right here. You know, they're just not going to be moving it, and you're going to have that clinical history of them being yanked up. Clinical diagnosis, no films needed unless you suspect there's a fracture. These are kind of one of these like really easy things. So here you go, just a little bit. Radial head dislocation just kind of pops out. And the treatment is this supination, inflection, and hyperpronation. So what you'll do a lot of times, you mind just kind of being a dummy just for a second? Just stand up. Just people. Sorry. So what you do is when you see these kids come in and they're examining them, I guess we can just turn sideways. There we go. What I'll do is they'll be in here and they'll be crying and they'll everything like that, and you just kind of get in there, and what you do is you just hyperpronate. So turn their hand in while pushing forcefully on that radial head, or you can kind of do it this other way too. But I think turning their hand, pronating in, pushing on this radial head, and get it like that. And I do that as my exam. That's both your exam, your diagnosis, and your treatment. And you'll feel it. You're just like, oh, your elbow hurts right here. Click, and it pops in, and they're like, they're still crying because they're kids, but then all of a sudden they'll start moving their arm a lot. So when you expect that, I mean, that's just part of your exam. Pick it up, grab it, turn it, twist it, put your thumb right over the radial head, push it in, hyperpronate that wrist, and pop that sucker back into place, and you'll feel it click. Sometimes you'll even hear it, but if you got your hands in the right spot, you'll feel a click, and it'll go in, and then 5 minutes later that kid is doing just fine. A little trick I like to use for after it's done. You know, a lot of times these kids, you know, they're children, and kids have a weird like pain memory. They like knew that hurt when it first happened, and they remember it for a long time. So they're still going to cry even when you come over to it sometimes. But what I like to do is I'll try to get like a sucker or a lollipop or a popsicle or keys or whatever, and I'll have them sitting in the mom's lap, and the mom holding down the unaffected arm, just holding it so that they only can use this one, and just kind of dangle the keys in their face, say, here, you want a sucker? You really want it? Grab it. And you kind of like pull it away, and then eventually they get it, they'll reach out for it, and that's kind of confirmatory that it's in the right spot. Because they weren't moving it before, hear the click, put it back in, they reach for that sucker, put it in their mouth, you're good. I don't even do x-rays on it, unless you think that it's, you know, they broke it or something like that, but a lot of times it doesn't. And so then you keep them there for a little bit, make sure they're using that arm, and then they go home. And man, you get a ton of RVUs on that. If you're working on RVU bonuses, good Lord, this is like, for something so stupid and simple, you get paid a ton of money for some reason. I don't know why. So make sure that you document that you did a closed reduction of a radial head dislocation, just for building purposes. And you did all that in like the span of 10 seconds. All right, epicondylitis. Medial would be a golfer's elbow, overuse injury, repetitive eccentric force coming through, opening up that joint. Lateral would be a tennis elbow for the backhand, right? Overuse external carpi radialis brevis, where that kind of connects right up there. Teres palpation, the lateral elbow. These are super, super easy things. Conservative treatment, NSAIDs, rest, ice, bracing, splinting, PTOT. They gotta stop golfing. They gotta stop tennis, at least for a little bit, or it won't get better. Can't expect to put a brace on it and take 800 ibuprofen and go out and play 18 holes every 3 days and expect your golfer's elbow to get better. It will not. Activity modification is huge. Any questions over that? All right, bicep tendonitis or rupture. More common in people who perform frequent pulling or lifting. These are going to be your weightlifters, day laborers, or just a normal dude that was just trying to lift something up and felt a pop. Rupture of the bicep tendon can be visible with palpable mass or hematoma. So it ruptures up here and then kind of just goes back down in here. Tendonitis produces pain at the insertion site. Speed test in Jurgensen's test. So speed test, patient's elbow is extended, forearm supinated, humerus elevated 60 degrees. The examiner resists humeral flexion and pain located at the bicipital groove. Positive sign, right? Jurgensen's test. This is the one I do right here. I like to put my thumb right at that insertion site, and what you kind of do is, you just come up in a handshake. Tell them to grab your hand, put your thumb right at that bicipital insertion site, and then tell them I want you to flex up or move against my hand. You push down and you push in with that thumb. Like, oh yeah, it hurts. That's where it is. And then some of them are like, I don't have any pictures of it, but just Google bicep tendon tear, and they'll have a huge hematoma there and a big old knot. You're like, well, that's a slam dunk diagnosis right there. Because those stuff, if it's a bad bicep tendon tear, the bicep itself is a highly vascular muscle, is going to bleed all over the place. Tendonitis, basic ortho treatment with activity restriction, bicep rupture, depending on age and activity level, depending on where it ruptured and was long or short head, whatever, you can try operative treatment, or sometimes they just leave it alone. I mean, you can still flex your arm. Bi means 2, so you got 1 left, right? So if they don't really want the treatment for it, then they don't need it, and sometimes other people want them to be reattached. All right. This is about an hour. I think forearm and the hand is the last half. I'm pretty sure the last time I gave this lecture, I finished a little bit faster. Every year I give these, I tend to get a little bit faster in doing it. So I think that we're going to be definitely good on time. If you guys want to take like a quick 5-minute break, and we can finish up with forearm, the hand, and then some other selected pathologies. I think I have like compartments and or something like that. So we'll say 5 to 10 minutes and come back. Cool.